So we start by the Neuropsychoanalysis of Trauma by Paul Moore. Paul Moore is from Dublin, Ireland. Paul Moore is a psychoanalytic psychotherapist in private practice in Dublin, Ireland. He's assistant professor in the Department of Psychiatry, School of Medicine at the Trinity College of Dublin, and the course director of the psychoanalytic psychotherapy and literature in psychoanalysis, a lot of things, of neuropsychoanalysis at the Trinity College. So we are going to talk about neuropsychoanalysis of trauma 10 years later.
Thanks, Rosa, and thanks to the organising committee for inviting me. I'm very happy to be here today. Neuropsychoanalysis is a dialogue that helps us hold biology and meaning together, and it keeps us anchored to one clinical question. What is it that changes in trauma treatment? I want to begin with a simple clinical image. So think of a person who cannot sleep, who scans the room even when nothing is happening, who cannot bear closeness but also cannot bear being alone. They may know intellectually that they are safe. Their body, however, does not agree. Their relationships do not agree, and their mind cannot switch off. So when I say neuropsychoanalysis, I mean a dialogue designed for problems like that. Psychoanalysis gives us a language for inner life, conflict, shame, desire, attachment, transference, and the meaning of symptoms. And neuroscience gives us a language for learning, arousal systems, memory, and prediction. So the point is not to collapse either into the other. The point is to let each one correct the blind spots of the other. So for much of the 20th century, these conversations were quite complicated, as we all know. Neuroscience was seen as reductionistic, and psychoanalysis was seen as untestable. And what is different now is that we can talk across levels without having to choose between them. So I will keep returning to one grounding question. What changes in a person with trauma such that life becomes more livable again? We're tracking more than symptoms here, or symptom scores. We're tracking sleep, trust, agency, and the capacity to stay with feeling without becoming flooded. So here's an outline for the talk. One, we will look at the clinical picture of PTSD and complex PTSD. Two, briefly review the core neurobiology of threat, memory and regulation. Three, explore the neuropsychoanalytic approach to predictive processing and active inference as a practical language for symptoms, including intergenerational patterns. No, it's next. This is the next slide. Still on the introduction. And finally, we will briefly review the evidence base for EMDR and trauma-focused CBT, and connect it back to psychoanalytic mechanisms. And throughout, I will make three claims. One, trauma is not only a memory from the past; it is an attempt to predict the present and the future. Two, most therapeutic change happens implicitly in relationship before it becomes a story the person can tell. And three, different therapies may look different, but they may share deep mechanisms. Our task as clinicians is more about fit and timing and less about ideology. Or, as in many cases, as Freud liked to say, the narcissism of small differences. So, therapeutic change does not depend on a person remembering what was said. It depends on implicit learning and relationship, and on updating expectations encoded in non-declarative systems. So let's begin with an observation that I believe can help to take us straight to the heart of the mechanism. In psychoanalytic work, people who are profoundly amnesic as a consequence of brain injury, the person may not remember sessions in the ordinary autobiographical sense, and yet they can still change. This allows for what we might think of as a clean separation between explicit, time-stamped narrative memory and the implicit forms of learning that shape feeling, action, and expectation. I would like to offer two brief examples from our neuropsychological research in Oliver Turnbull's Emotion Research Lab in Bangor, North Wales. because they clarified this distinction in an unusually dramatic way. So first, JL was the 38-year-old man who developed profound anterogreed amnesia after a ruptured anterior communicating artery aneurysm. In everyday terms, he could not form new episodic memories. He could not hold a short conversation, but he could not later remember having had it. Sorry, he could hold a short conversation, but he could not later remember having had it. He lived in a kind of permanent present, quite similar to the classic case in the neuropsychology literature of patient HM. Despite that, he engaged in psychoanalytic psychotherapy weekly over 2 years. And the striking clinical observation was that the therapeutic sessions seemed to matter to him. Over time, he became less anxious, he became less prone to catastrophic, emotional, angry outbursts, and he became more aware of his emotional states. Slow down, okay. All right. I thought I was going slow. Okay. So he could tolerate. He became more aware of his emotional states in the moment, and he could tolerate frustration better. Staff and family observed that he was more settled and more socially connected. We could also see a change in the relationship in the consulting room. He came to expect the therapist. Okay. Okay. Thanks, Claudia. Okay, he became less suspicious and less avoidant. He started to bring more affective content into the room rather than discharging it elsewhere. Now, here is the paradox. At the start of almost every session, JL would say he had no memory of previous sessions. He could not recall what we had been speaking about, what interpretations had been offered, or what emotional content we had discussed. The explicit story was absent, and yet the emotional and relational learning was present, and its continuity could be discerned by listening with a psychoanalytic third ear. It's interesting to note what JL could do in the room. He could recognize tone, he could register warmth or distance, and was able to work collaboratively and problem solve. Might we think of this as the capacity to create shared generative models? He could build and maintain a therapeutic alliance through transference, countertransference phenomena. These are not episodic memories, they are implicit forms of learning and remembering. In other words, the therapy was not primarily stored as episodic memories about what had been said or declared. It was encoded and stored at an implicit, non-declarative level within the mind-brain. And when we come to talking about the predicting coding and the free energy principle, we might think of it as as a shift in the confidence with which he predicted what would happen when he brought his mind in contact with another mind. More of this later, I'm just flagging it here. And clinically, that is close to what we often hear Peter Fonagy talk about, what he calls epistemic trust. So trust is not a belief statement. Trust is an implicitly learned memory that I am safe here in this space. So the second case is the case of GA, who was 19 years old when he developed amnesia after a traumatic brain injury affecting a structure called the fornix, which is in the limbic system. This disrupted the pathways that support episodic memory. Like JL, he was unable to hold a narrative thread from one session to the next. And yet, he too showed a capacity for implicit learning. He learned routines, he could navigate through the building where his therapy session took place, and he learned to move from the waiting area to the therapy room and to the toilet if he needed it. He, like JL, learned implicitly what kind of mind the therapist had and that it was safe to be in his presence. He could become calmer in that setting, often after entering in an agitated state. And when I would point this out to him, he could not remember or indeed explain why that might be the case. A particularly striking detail was his eating behavior. In residential care, there were frequent episodes of hyperphagia. However, in the therapy setting, this did not appear once, across 56 sessions, approximately 18 months. Something about that context, the therapy context, changed his state of regulation, and even though he could not explicitly recall the rules of that context. So, what do these cases tell us? They demonstrate that mechanisms of therapeutic action do not depend on episodic recall. They depend on implicit procedural and affective learning, on autonomic regulation, on expectation, and, in my view, most importantly, on the repeated experience of a particular kind of relational safety. So psychoanalytically, we might think of it as transference and countertransference, not being primarily verbal. They are lived, implicit, cognitively implicit, embodied, procedural, and affective. The patient learns about the therapist as an object, like Gilbert Pugh's concept of memory objects. That learning is stored in systems that do not require narrative memory. Importantly, more than this, these systems are independently dissociable. They do not communicate with each other, and even more importantly for our clinical work, the theme of this conference and this particular presentation, the declarative, explicit, and non-declarative implicit memory systems speak a completely different language to each other. And as we will soon see, the information being processed, encoded, and retrieved in each of these systems are of entirely different natures qualitatively. So in the register of neuroscience, we might say, non-declarative memory systems can learn and update, even when declarative systems cannot. The body learns, attention learns. The confidence settings of the system are essentially adaptive and can learn. We also recognize this as consolidation and reconsolidation of memories in these systems. So these cases also provide a disciplined way to think about trauma treatment more broadly. So to sum up this section of the presentation, we can say that trauma is a disorder of learning and prediction and psychotherapy, and I believe, based upon the information on what we covered today, that psychoanalytic forms of psychotherapy especially is a modality where implicit expectations can be updated, often before the person is capable of declaratively articulating the change. So is that okay? Can everybody follow me? Yeah. Okay. Okay. So PTSD is not only a bad memory, it is a change in how reality is predicted and organized. And complex PTSD extends this into models of self and relationship, as Andrea has spoke about previously. So we have a shared phenomenology in relation to trauma across multiple modalities of mental health treatments. PTSD involves intrusions, avoidance, hyperarousal, and negative shifts in mood and cognition. People are pulled into reliving, or they organize their lives to prevent it. So the person implicitly expects to encounter danger in the environment, in other people, and even in their own body. This is why reassurance frequently doesn't work. The implicit expectation completely overrides reassurance. Complex PTSD expands the target beyond fear memories into the deep psychological and biological architecture of self and relation of self with other. In ICD-11 terms, it includes the core PTSD symptoms plus what is commonly referred to as DSOs, as Andrea mentioned, disturbances in self-organization, which can include chronic affect dysregulation, a persistent negative self-concept, and extreme difficulties in relationships. So clinically, that might look like a person who struggles with regulating shame, who expects abandonment or attack in ordinary everyday closeness with others, and who oscillates between clinging and withdrawal. Essentially, a person who never really feels safe in themselves. So the distinction between PTSD and complex PTSD points to different layers of the generative models that organize a life, such as threat models, self models, and relational models. And those models become the real targets of treatment. So just a brief overview of the core neurobiology. Much of this has been mentioned already. So threat and memory are distributed systems. The key clinical issue is how regulation and context fail and how implicit memory keeps shaping the body and relationships. Most of us are familiar with the landscape at the level of broad circuits and systems. The amygdala and related networks support affective, and in the case of trauma, threat, learning, and salience. The hippocampus supports context and time stamping. Medial prefrontal and anterior cingulate regions support regulation, appraisal, and flexible control. Brainstem and hypothalamic systems coordinate autonomic and endocrine responses. So clinically, trauma tends to bias the system towards alarm, and it reduces the flexibility, as Francesco mentioned, of regulation. The same cue that is neutral for one person becomes loaded for another. The present is constantly contaminated by the past. Put simply, the hippocampus timestamps our experience and helps us to say, that was then. When its contextual tagging is compromised, the body reacts as if the past is present. The medial prefrontal systems that support inhibition and reappraisal can then be overwhelmed and overridden by the alarm system. The result is that what was past is now present. There's no comprehensive integration resulting in complete memory or remembering as would ordinarily be the case. So clinically what matters most is the pattern. This is the dynamic aspect that Georg was mentioning. Threat signals are amplified, regulation is compromised, and context is lost. The person reacts as if now equals then, and the body acts as if it is still trying to survive. So this brings us back to the memory systems. Explicit or declarative memory mediated by hippocampal, parahippocampal, and medial temporal lobe structures support the creation of a narrative that can be temporarily situated. Implicit or non-declarative memory includes procedural and affective learning, priming, and body state associations. It is often the implicit systems that drive symptoms. This is why people we work with can say, with all sincerity, I know it's irrational, but I still feel terrified. The explicit system knows one thing, the implicit system expects another. So our work with profoundly amnesic persons illustrates this with spectacular clarity. The explicit record of shared experiences with the therapist is absent, but the implicit learning of safety, trust, and expectation is very much alive and present in these people. A further piece to consider is reconsolidation. So when a memory is reactivated, it can become labile and then restabilize in an updated form. Joe Ledoux's work speaks to this. This is one reason why psychotherapy can produce durable change. Old expectations can be brought into the room, met with a different outcome, and then restored differently. If we say this in predictive language, reconsolidation is an especially privileged window for model updating. If we extend this logically, the clinical challenge now becomes, how do we open that window without flooding the system? How can we bring the old prediction into our work while keeping the person within safe enough parameters where thinking remains possible? So, just to tie all this back to a clinical perspective, a patient may understand cognitively that their partner is not their abuser, and yet when the partner raises their voice, the patient's body reacts with the same alarm, the same urge to flee, and the same certainty that harm is coming. That is implicit memory and prediction, not volitional and deliberate choice. When therapy works, it often works by changing that moment, not by telling the person they are wrong, but by slowly building new experiences of affect, rising and falling without catastrophic subjective consequences. So the old, strongly consolidated prediction can finally loosen. So dissociation is, I think Georg and Andrea covered this quite nicely earlier, is often a protective strategy. It reduces overwhelming prediction error in the short term, but it blocks integration and keeps the system stuck. We might think of dissociation as what happens when the feeling of fear becomes unbearable. Many of you will recognize this clinically. The person may glaze over, become blank, distant or absent. They may speak about horrific scenarios with a jarring and peculiar absence of affect, or they may feel unreal or feel their body is not theirs. So evidence from a research paradigm known as script-driven imagery studies show different profiles in trauma responses. Some people relive with high arousal and vivid sensory detail. Others show a shutdown profile, numbing, depersonalization, derealization. Physiologically, they may show blunted responses rather than hyperarousal. In predictive terms, we might think of the dissociative profile as employing an uncertainty reduction strategy. If the system predicts catastrophic overwhelm, shutting down becomes a coherent strategy that brings about reliable and more certain outcomes. It's a circuit breaker and prevents experience from exceeding the person's capacity to metabolize it. This can be life-saving in the original context of trauma. The problem is that the response to trauma generalizes. It turns up in therapy, in relationships, in daily life, and becomes increasingly more consolidated and reconsolidated. Dissociation prevents the integration of experience into narrative and meaning. It blocks learning. If you can't take in new information, you can't update internal models or schemas. Ultimately, it fragments self-experience and it undermines trust in one's own mind. So this is where the clinician's judgment matters. How much mismatch between expectation and necessary and realistic appraisal of any given situation is therapeutic, and how much is destabilizing. As clinicians, we are always titrating. I'm thinking of Anne Alvarez's concept of levels of analytic work and levels of pathology here. The goal is not to abolish defenses. The goal is to make thinking possible in the presence of affect. Practically, this means that when dissociation appears, our first job is not interpretation. Our first job is contact. We slow down. We reorient to time and space. We notice the body. We name what is happening in simple language, and we help the person to stay connected with us and linked to us while the affect rises and falls. It is only then that meaning can become available. Dissociation is the sign that the overall system of the person has left the zone where meaning making is possible. So I would like to propose a neuropsychoanalytic stance that is less about mapping metaphors onto brain parts and more about translating process at the level of functional systems. The psychoanalyst Wilfred Bion offers a particularly useful transformational model. His concept of alpha function is the capacity to take raw sensory and emotional experience, which he terms beta elements, and render it into something he calls alpha elements, that Ogden says doesn't exist. I kind of agree with him in a way. Which, as a result of this transformation, are then thinkable, dreamable, and shareable. It is the capacity to fully have an experience rather than be had by it. Carl Jung said something similar. Sometimes we have ideas, and sometimes ideas have us. So you can hear this in the clinic when a patient moves from, I do not know, I feel nothing, to, I think I felt ashamed there, or I felt frightened and I didn't know it. That shift is a marker of therapeutic progress, albeit not always present. And when we take a step back and think about it, a remarkable change in mental functioning has taken place. When alpha function fails, experience is not metabolized. It is enacted, somatized, or split off. In trauma, especially complex trauma, the person often comes with a chronic expectation that affect will overwhelm or destroy. So they avoid feeling, or they dissociate, because feeling is predicted to be dangerous. In predictive language, you can think of alpha function as improving the system's capacity to tolerate prediction error. It allows experience to be held long enough for updating to occur, rather than being immediately evacuated and discharged through action or shutdown. Again, our work with profoundly amnesic people as a consequence of brain injury is a reminder that this transformation can happen implicitly. The patient may not remember what was said, but their system learns what it's like to be with another mind that can hold and contain them. And that becomes a new expectation. According to Bion's model, the therapist's task is to receive what is projected, metabolize it, and return it in a form the patient can bear. This is reverie as a clinical tool and in the service of improving mental functioning. Over time, the patient internalizes this capacity and they begin to do it for themselves, what the therapists have been doing for and with them. This is one way we might describe the development of self-regulation and the restoration of dreaming. So predictive coding, in a nutshell, says that perception is an inference. The brain predicts what it is about to sense and then updates those predictions based on incoming signals. It's quite profound when you think about it. Think of our neurological patients mentioned earlier. The system is always balancing two things: prior expectations and sensory evidence. Prediction error is the mismatched signal, a function of the difference between what the system expects to happen and what actually happens. Updating is what happens when the system revises its expectations. So the crucial clinical variable is precision, which you can think of as a confidence level. If a prior is highly precise, it dominates experience and resists updating. If sensory evidence is treated as highly precise, the system becomes jumpy and unstable. Either way, the person suffers. If we apply this to trauma, hypervigilance looks like overly precise threat expectations. Ambiguous cues are read as danger. A neutral face is read as hostile. A sudden noise is read as attack. Avoidance becomes intelligible as a way to keep the model stable by limiting disconfirming evidence. If I never test the world, my belief stays intact. It's a strategy to keep the system from becoming destabilized. Intrusions can be understood as prediction errors that do not settle into an integrated model. The system keeps reissuing the same unassimilated signals. The person feels as if it is happening now because the model cannot place it in the past. In complex PTSD, the priors are about self-worth, bodily safety, and relationships. A patient may predict that closeness equals harm, that anger equals abandonment, or that desire equals shame. Those are relational priors, frequently learned very early in life, and in many cases at pre-verbal stages, and they feel like facts in the here and now for the person. Again, this highlights why simply telling a patient their predictions are inaccurate rarely produces change. From their subjective perspective, these are not hypotheses, they are reality. Us clinicians understand this as weighting our interventions carefully and our interpretations. As Ferro would say, we need to wait until the intervention, the link we are offering, is cooked properly and al dente. The therapeutic task is to make them testable and to make the testing survivable. And when testing becomes survivable, it usually becomes survivable inside a relationship first, before it becomes survivable in the wider world. In psychoanalytic terms, many of the phenomena we describe, including enactments and projective processes, can be seen as attempts to manage prediction error in relationship. The patient acts to shape the other so the familiar pattern repeats, because the unfamiliar feels dangerous, even when it is good. We might think of this as being similar to what we recognize as projective identification. So, predictive processing does not replace psychoanalysis. It is an adjunct to our psychoanalytic theory and technique, providing us with an additional way to describe and formulate why the repetition compulsion can feel so compelling and why change can feel like threat. So predictive accounts can make behavior look coherent rather than defective. If the internal model predicts danger, then withdrawal, checking, numbing, or control can be intelligent responses to that predicted world. Putica and colleagues have argued that PTSD can be understood as predictive processing within value-based learning. Trauma shifts valuation, and consequently in PTSD and CPTSD, safety now becomes the dominant currency. The person becomes entirely organized around avoiding loss rather than pursuing life. Clinically, this is what we see when a person says, I don't do anything anymore, but at least nothing bad happens. So life shrinks in the service of safety. Our task, as it were, is to help the person stop looking away from the difficult to look at things, and in most cases, slowly over time, build the capacity to look at the difficult to look at things in their lives. So we ask, what does the person treat as valuable? What do they treat as evidence? What actions do they take to keep the world predictable? Where is choice and where is compulsion? So this is also where, in my view, psychoanalysis can make unique contributions. It gives us a conceptual framework to formulate how guilt, shame, desire, and attachment organize the person's predictions, and how defenses protect them from precisely the experiences that would allow new learning. So the concept of active inference is a slight kind of adaptation or advancement of predictive coding. It takes the predictive idea further. So in addition to prediction, self-organizing systems, like most living organisms, actively sample the world in ways that confirm or stabilize their models. So we have a practical sequence that goes something like this. A model predicts, the self-organizing system selects an action policy, and then it takes in new evidence. The action policy of avoidance is a policy that prevents disconfirmation. Checking is a policy that reduces uncertainty. Perfectionism, for example, can be a policy that tries to prevent humiliation. And shutdown in this context is a policy that minimizes unbearable signals. So this is why symptoms can be so stubborn. The symptom is not only an outcome, it is also an action that keeps the model intact. Active inference also helps with relational symptoms. Many trauma strategies are interpersonal. The person may test, attack, withdraw, appease, or control. These actions shape the partner's response, which then become evidence that confirms the underlying expectation. So, now let's just briefly add the intergenerational dimension into the mix. So in addition to inheriting their genes from previous generations, children also inherit patterns of attention, arousal, and expectation in the caregiving and broader environment. If a parent is organized around threat, the child learns a world in which safety is scarce and vigilance is necessary. Intergenerational trauma is transmissible through ordinary psychological mechanisms, modeling, attachment patterns, family narratives, silence, and the daily calibration of what counts as safe. In some families, danger is named constantly. In others, danger is never named, but it is lived in the atmosphere. There are also biological embedding pathways. We heard this in the remarkable presentations given to us in New York last summer by Michael Meany and Catherine Monk. Prenatal stress exposure can influence fetal development through maternal stress physiology, immune signaling, and epigenetic modifications. Early caregiving then tunes stress responsivity further. Across development, these layers accumulate into a body that expects danger quickly and calms slowly, heralding in a host of lifetime health, social, and socio-economic challenges for these children. Both speakers alluded to biological mechanisms that transcend generations, but they hinted that this work was forthcoming. So clinically, this might show up as a person who feels they have always been anxious or always bracing themselves for the worst, as if their nervous system came into the world already prepared for impact. So again, the clinical question becomes, what predictive model is keeping this person's symptoms coherent? And if there is an intergenerational component, whose model was it originally? The work can become not only personal, but familial and historical. We see this a lot in our clinical work in Ireland as we emerge as a society from centuries of trauma resulting from colonialism and oppression. So for example, a parent who has lived through war may never speak about it, but they flinch at loud sounds, they monitor the door, they distrust strangers. The child grows up in that atmosphere and learns implicitly that the world is unpredictable and unsafe. And later in adult life, the child may call it anxiety, but we, in active inference terms, we might think of this as an inherited style of prediction, or what Carl Friston would call a shared generative model. So a slight change of tack here. So when planning for this section of the conference, Francesco asked me to review the evidence base for EMDR and CBT. So let's turn to that now briefly. From the research literature, EMDR appears to be a widely used trauma treatment. In a typical EMDR session, the patient focuses on a traumatic memory while engaging in bilateral stimulation, often eye movements, but it can be other forms. And the therapist guides the process. There are multiple theories out there about how EMDR works. Shapiro's original model emphasized adaptive information processing. Other accounts emphasize working memory load, orienting responses, or neurobiological integration. The literature is less clear about this. What matters is that EMDR reliably reduces PTSD symptoms for many people. A recent evaluation by Wright and colleagues using individual participant data meta-analysis arrived at a clear finding. EMDR works. It reduces PTSD symptom severity and improves related outcomes. The same analysis also reports something important for our clinical position. EMDR was not statistically superior to other bona fide psychological therapies on average. That includes trauma-focused CBT approaches. Another way of putting that is that EMDR belongs in the family of effective treatments rather than standing above the family. So in what are referred to as moderator findings, which is a deeper investigation of the factors associated with outcomes, which are also clinically useful, they suggest that context matters, including practical adversities in the person's life and the capacity to stay in treatment, which means that it's difficult to disentangle circumstantial factors from treatment modality. And we have to pay very careful attention to that clinically. So in what's also referred to as dismantling studies, an attempt to get at individual components of a treatment modality, suggests that eye movements may add something unique to the EMDR approach. But it seems that the overall therapeutic package matters, which is good news for our psychoanalytic modalities. From a reconsolidation and predictive perspective, EMDR may be one structured way of reactivating traumatic material while maintaining enough dual attention and regulation for updating to occur. The bilateral stimulation may function in part as a regulator of arousal and attention that keeps the person within the window where thinking remains online. Most major guidelines, NICE, WHO, APA, etc., list EMDR and trauma-focused CBT as first-line treatments for PTSD and CPTSD. Psychoanalytic therapies are often less represented in these guideline lists, largely because the evidence base is smaller and harder to standardize, not necessarily because the clinical phenomena are different. That's an old story in the outcome and efficacy studies domain. So I'd refer you to the work of Jonathan Shedler in that regard. So the question for us as clinicians ought not to be which brand wins. It should be which intervention matches this person at this time with this level of stability and with these specific set of relational meanings. This is where the integration matters. Again, we are back to what we call the art and science of clinical judgment in psychoanalytic work. One useful way to explore this further is to try to separate outcomes from mechanisms. We know that structured trauma-focused treatments can reduce symptoms. The neuropsychoanalytic question is, what changes inside the person to make that possible? Frequently, it is a shift in arousal, regulation, a loosening of avoidance policies, and a relabeling of affect from danger into what Freud might have referred to as signal anxiety. Different treatment modalities may reach those changes by different routes. Some are more direct, some are more relational, some are more explicitly narrative, but none of them work without some degree of safety, some degree of tolerable activation and reactivation, and some degree of new evidence in the interpersonal field. So when we think about psychoanalysis in this landscape, we can ask, what does psychoanalytic work uniquely add? I would suggest it's a disciplined attention to the relational priors, and including, in context, specific post-conflict situations, intergenerational priors. It helps us see how, as Mark Soames says, memories are about the past, but they are for the future. And that helps us work with the resistances that appear precisely when the world begins to look less dangerous. So, importantly, equivalence in outcomes does not mean the treatments feel the same. EMDR is often experienced as focused, structured way to work directly with traumatic material while keeping one foot in the present. Trauma-focused CBT often emphasizes skills, meaning-making, and behavioral experiments that are designed to weaken avoidance. Psychoanalytic work often emphasizes the relational field, where the trauma is relived as expectation and enacted as pattern. So there is an additional interesting dimension in the research literature. When we turn to look at complex PTSD in this context, it brings us to a major debate. What is the question? That is the question of whether we should place an emphasis on stabilizing the person first or process their trauma immediately. What is referred to in the literature as the phase-based approach typically involves 3 stages. First, stabilization and skills, such as safety, grounding, affect regulation, and relational capacity. Second, direct trauma processing. Third, consolidation and reintegration. The alternative view argues that delaying trauma focus can prolong suffering, and that many people can benefit from early trauma processing if the treatment is well structured. So trials such as TOPRON, TREAT, or I can't remember the rest of that actually, have been designed to compare these approaches. The wider literature suggests a nuanced picture. Phase-based work can help with emotion regulation and interpersonal function. Immediate trauma-focused work can also be effective. And for some people, it is exactly what is needed. From a predictive and neuropsychoanalytic perspective, we might think of the core variable as being prediction error tolerance. How much mismatch between model and reality, broadly speaking, the world, and me as an agent in the world, is actually safer than I predict it to be? And can the person bear this without dissociating, collapsing, or becoming dangerous to themselves? For some, early trauma processing is possible and helpful. For others, stabilization is not avoidance. It seems to be factors like relational trust and affect containment that make later updating possible. The building of alpha function under conditions of safety. So again, our job is clinical evaluation and timing. We titrate mismatch, we pace exposure to meaning, and we monitor the person's capacity to stay in contact. As clinicians, we are looking for indicators of flexibility versus fragility. Things like, is there severe dissociation that disconnects the person from time and space? Is there active self-harm risk or chaotic substance use that makes activation unsafe? Is there enough social support to recover between sessions? Can the person mentalize, even briefly, when upset? Or do they regress and default back into action? I suppose these are estimates of capacity, really, and they help us decide whether to begin with stabilization, with trauma focus, or with a rhythm that alternates between them. And as I went through this literature, I was surprised by how much us psychoanalytically trained, last slide, just perfect. I was surprised by how much, as psychoanalytically trained clinicians, we are already inherently doing this in our space. Okay, so let's try to gather all of this up. So whether we call it working through, reconsolidation, or model updating, the aim is similar: to loosen overly rigid predictions and restore flexibility. Three conditions need to converge. One, prediction errors must be generated. The person must encounter evidence that contradicts trauma-derived expectations. Two, the mismatch must be tolerable. It needs to be experienced and, more importantly, felt, but ideally not overwhelming. And three, the systems of the person in therapy, the therapist, and the joint therapeutic relational space must have enough capacity and flexibility to update rather than defend or shut down. So intuitively, the therapeutic relationship may be the primary vehicle for all three. The relationship generates new evidence, it regulates arousal, and it supports the thinking function that turns raw affect into meaning. And I believe this is where psychoanalytic work is powerful, because it takes the relationship itself as the main instrument. Thank you very much.